First of all, and I can hear that you're recording. Great. So, thank you, Gloria. Like she said, I'm Dima. I work at the Royal Marsden, where I treat patients with lymphoma, including WM, and also I am lead for our diagnostic unit, so involved with the diagnosing of WM as well, looking down the microscope at bone marrows. And when I saw Gloria at the last WM European Summit, I think was the last time we saw each other. We spoke about what might be useful to talk about today, and both she and I thought that just talking about the immune system more generally would be very useful. So hopefully you all agree with us. So I'm going to start off by making some apologies about the kind of language that I'm going to use in this talk. So a lot of the time when we talk about treating cancer in general or WM in specific, we use a lot of battle analogies or military analogies, and especially in this day and age with what we're hearing in the news and the threats of things, whilst it can be helpful to think about things as a war in your body, also it sometimes depersonalizes it. So I apologize if those analogies are offensive in some way, but they do help bring some points across. So before we talk about what goes wrong, I think that we really need to start with what is the immune system and what your immune cells are. So the immune system technically is any line of defense against foreign objects in your body, such as infection. So, it's not just about the white blood cells fighting infection, but in some ways you could think about your skin being part of your immune system because that's blocking physically a lot of pathogens from coming in and entering the body. Obviously, when we're eating things, we've got mucous membranes, or breathing things in, we've got mucous membranes in our nose, throat area that are also there in part to form some protection against some of these pathogens. And then internally, we've got part of our lymphatic system and the white cells that help form our defensive system internally once the pathogens have entered the body. So as I've said, the skin is the first line of defense, and when that breaks, then potentially we're more prone to infection. So, things can still enter through other ways, but that makes it easier for infections potentially to develop. But when we think about the immune system, most of the time what we're focusing on are what cells contribute to the immune system. So this is basically the tree of life for hematologists. This is what particularly hematologists that are interested in blood cancers live, eat, breathe kind of thing, because this is essentially how our cells develop in our bone marrow. So a lot of you, I'm sure, will already be aware of this, but in your bone marrow, so that's in the middle of your big bones, you have got stem cells that have the ability to replicate, so to keep renewing, and then differentiate, so divide and become ultimately one of your more mature blood cells that all each have different infections. So stem cells can either go down the myeloid route or the lymphoid route. If they go down the myeloid route, then eventually they become your red cells, which help carry oxygen around the body, your platelets, which are the little fragments of cells that help your blood clot, or some of your white blood cells, so the ones that have granules in them, like the neutrophils, eosinophils, or basophils. Your stem cells can also differentiate down the lymphoid route and eventually become either B lymphocytes or T lymphocytes. And some of your B lymphocytes can become plasma cells, which are the antibody producing blood cells, which we'll talk about shortly. So essentially, your immune cells, the ones whose function is to fight infection, are all these different white cells. So your granulocytes, which are primarily your neutrophils from the myeloid route, and your lymphoid cells, which are your B lymphocytes and T lymphocytes. So these are the cells that help fight infection. So when we think of your myeloid cells, the ones that are the immune cells, so your neutrophils, monocytes, eosinophils, they form part of the innate immune system. And what we mean by innate is that they're not really targeted to a particular infection. They will just, if they see an infection, if they see something as foreign, they will just deal with it if they can. And I got this video, hopefully it is going to play for us, from the internet, but I thought it's quite a nice way of visually seeing how a neutrophil literally engulfs a bacteria. So here we've got blood, and here we've got a neutrophil, and here we've got some bacteria, and I'm going to press play on this, and you can see that the neutrophil recognizes it as foreign and is trying to chase it, and eventually will engulf it, and it would do this regardless of the type of pathogen. So it will do the same thing whenever it sees something abnormal. And I think these images are amazing. And when I was getting it, I think there were some comments from YouTube. So you can see it's within the neutrophil and then it gets destroyed there. When I was seeing some of the comments on YouTube when I had borrowed that video, I think people were saying, oh, it's like Pac-Man in your body. And I thought that was quite a nice description. Oh, that's it again. But I think we've seen that. So that's what we would call innate, that it's not adapted to the type of infection. It will just treat all infections the same. Whereas the cells that I tend to deal with from the lymphoma side are the lymphoid cells, which are more adaptive cells. So I've put it as the thinking man or woman cells, because they're the ones that are more specific and target specific infections. So you've got B or T lymphocytes. There are also NK cells, but I guess less is known about them. There's far fewer of them in the bone marrow, so I'm not really going to focus on those. But all your lymphocytes are produced in the bone marrow, like all your blood cells are. And why we differentiate and why we call B lymphocytes and T lymphocytes is where those lymphocytes mature. And your B lymphocytes mature in the bone marrow, hence B, and your T lymphocytes mature in the thymus gland, so hence T, and that's where those letters came from. So they work in slightly different ways. So your B lymphocytes, one of the ways that they help fight infection is that they produce targeted antibodies or proteins that can kill cells it recognizes. So I've kind of got a little cartoon, very basic schema here where you see that, you know, this cell here that's got the square key, if you like, is only going to be able to target infections or bacteria that has the corresponding protein that it recognizes, whereas a different one is going to recognize a different bacteria. So that's what I mean by targeted. So this one's not going to help target the one that this targets necessarily. And T lymphocytes also can kill cells that they recognize as foreign. And both of these cells undergo changes at the DNA level that help them target their specific foreign object or part of the proteins that they recognize as foreign. So they can undergo normal immune changes that make them specific to that particular infection. So again, I've taken this from a paper, which was just to show that B cells kill by antibodies that are specific. So if you've got a B cell that's producing an antibody that targets the measles virus, if you contract measles, then it's going to be very good at treating the measles virus, but the B cells that produce antibodies against the mumps virus are not going to be any good for this infection, whereas if you contract the mumps virus, the converse is true. The T cells don't produce antibodies that they release, but it's kind of by direct binding with either a cell that is helping it to kill the pathogen or by directly killing the cell. It works, but it's still that specificity that leads to it targeting the pathogens that they target. And there is interplay between the B lymphocytes and the T lymphocytes and some other immune cells that they all help each other. And so then this is my analogy here. I grew up in Wales, and this was a picture of an English supporter at, I think, a football match rather than rugby match in the middle of the Welsh supporters. But he would be recognised as foreign by the lymphocytes and ejected out. So lymphocyte response to infection. So if the B cells or T cells recognize the proteins on the infection, so like this London soldier here, they send signals to increase the number of cells that specifically target that infection. So if this soldier here saw the infection that it recognized, whether that be the measles or mumps in those examples before, then it recruits his friends to then come and strengthen the army against the infection. And once the infection has been treated and resolved, then they go down in number because they're no longer needed anymore. But you get these memory B cells, so these older B cells that have been exposed to the infection, that remember the infection, so that if that same infection comes back, then they can quickly recall all their friends again to treat it. And that's why often the second or third time patients with a normal immune system are exposed to the same infection, they don't get the same severity of disease unless that infection has changed, such as, the flu virus changes from year on year, which is why we get repeated infections with something like that. Now, I should say that this is an oversimplistic overview of the immune system, but does give you a bit of background as to what the immune system is. So now that we kind of know what happens when it's going right, what could be the potential things that go wrong with the immune system? So when it goes wrong, the way that I see it is that either the problem is that you've got autoimmune problems, so that the lymphoid cells, the ones that are the targeted cells to infection, actually are targeting the wrong proteins, and they're targeting your own cells rather than foreign cells. So that's what we mean when we say autoimmune diseases. So, for example, there's lots of different autoimmune diseases, but rheumatoid arthritis is one where we know the lymphoid cells are targeting often the joints. There's other autoimmune diseases, and we know that I think there was a recent paper showing that in big population studies, people with autoimmune diseases with this overactive immune system are at slightly higher risk of developing lymphomas such as WM than people who don't have an autoimmune disease. So there may be something, constant activation of the immune system, that potentially predisposes patients with these kinds of conditions. So that's where the lymphoid cells can't distinguish your own body and your own cells from foreign ones. There's allergy, where things that are generally not considered infectious agents, whether that be, dust, fur, all the things that tend to cause allergy, but for some reason your body recognizes them as foreign and then builds up this, not just a reaction and a normal reaction to that thing, but a hyperimmune response. So they go into overdrive, so that actually when you've got an allergy, the problem isn't the dust itself, it's your immune system's overreaction to the dust that causes the runny eyes, the runny nose, or more severe things in severe allergies. Other things that can go wrong with the immune system, that you just don't have enough of the normal cells. Now, there are some people that are born with problems where they're just not producing one or all of their immune cells. And again, they'll be more prone to infections and problems because those immune cells aren't there in enough number. And we'll come on to some of the what we call secondary causes of not enough immune cells. So we know if you have, for example, a lymphoma, many people might have low blood cells, including low white cells, as a result of all the abnormal cells reactions. So there could be problems in terms of numbers, either that you're born with or what we call acquired to other things going on. Or the issue may be not that there's not enough of them, but that the cells that are there are not functioning properly in the way that they should. Again, predisposing patients to infections if they're not doing the job that they should do. And of course, the other thing that you will all be very well aware of because you are attending this webinar is that the other thing that can go wrong with them, like most cells in the body, that they can become cancerous. And so just a brief overview in case any of you are new to WM or lymphoma. So lymphoma is a cancer of lymphocytes at its simplest. And cancer is an overproduction of cells that continue to grow and divide. These cells, by their very nature, are what we would call scientifically clonal because they all divide essentially from the same starting cancer cell. Then they all look exactly like that cell. Whereas, lymphocytes, the way that they target different infections is that they all look different from one another. So we sometimes refer to that as polyclonal. And if you were to look at their DNA, they would all be different DNA. That would help them to be specific to different pathogens. But with the lymphocytes, when you look at their B cell receptors and the bits of DNA that encode the proteins that target them to certain infections, that would all be exactly the same in a cancerous clone of cells. And so the only way to diagnose the lymphoma, to see those abnormal cells, is a biopsy. So we can be suspicious of lymphoma from potentially blood tests if you happen to have a paraprotein checked and it's picked up, or you have a scan that shows enlarged lymph nodes, for example. But the only way to be absolute is a biopsy and to see those abnormal blood cells. But as I'm sure you are all aware, lymphoma in itself is not a final diagnosis because we have lots of different subtypes of lymphoma. So we've got B lymphocytes and T lymphocytes. We've got B cell lymphomas and T cell lymphomas. We've got a particular type of B cell lymphoma called Hodgkin lymphoma, and anything that's not Hodgkin's comes under this umbrella term of non-Hodgkin's lymphoma. And within the B cell non-Hodgkin's lymphoma, we've got high-grade and low-grade lymphomas, and that just really reflects how quickly the cells are dividing. And as I'm sure you're mostly aware, that WM is a low-grade B non-Hodgkin lymphoma. So in terms of the symptoms that you may get from the lymphoma, I tend to think of it in three kind of compartments, if you like. You may get the problems with the lymphoma, abnormal cells causing swollen lymph nodes or enlarged spleen, which we might pick up on a CT scan, for example. And if you've got a heavy burden of disease with lots of bulky enlarged lymph nodes, then you might get quite generalized symptoms as well as noticing the lumps. So you might get fatigue, weight loss, night sweats. A lot of people with WM don't have enlarged lymph nodes because it does seem to tend to just stay in the bone marrow, but we do have some patients who do have enlarged lymph nodes with their WM. The second bit is the symptoms from the lymphoma affecting the bone marrow, which I think primarily with WM it does. And like I showed you that tree of life for hematologists, what the symptoms you get when you've got a heavy infiltration of the bone marrow with abnormal lymphoma cells is that you get low normal blood count. So you might get anemia, and that would present with shortness of breath and tiredness. Low platelets, that would present with bleeding and bruising. And if you've got low neutrophils, so those are the cells that, remember, that fight pathogens from a part of your innate immune system, there is an increased risk of infections. And then the third thing, or third compartment that I think of that's more specific, I guess, to WM, because most patients with other types of lymphomas don't have a paraprotein, although we do have some that do. You can get problems related to the paraprotein as well. Either if it's at very high level, then that's the hyperviscosity, where it can affect basically small blood vessels in your body. So people may get nosebleeds, headaches, changes in eyesight, kidney impairment. And these paraproteins are basically the abnormal antibodies that are being produced by the abnormal lymphoid cells. So rather than these, if they were functioning normally, would be antibodies that would be targeting infection, but because they're being produced by abnormal cells just of their own free will, not because there's an infection there, then they're what we would call non-functional. So they don't really work properly, and they in themselves can cause problems. As well as problems related to the level of the paraprotein, you can get some patients with WM can get complications specific to their paraprotein, and I've just listed a couple of examples there with the neuropathy and the amyloidosis. So that's just, I guess, a brief aside on WM and how it really relates to the immune system. But I guess the main focus of this webinar and the discussion after will be on really how does the lymphoma affect the immune system. I've already told you that some people's immune systems may predispose them to lymphoma, but we know once patients have lymphoma that can have an impact on the immune system. So we know that from a paper from, the largest group in the US, it was Trion's group, looked at 200 of their patients with WM to look just simply at what their level of normal antibodies were. So everyone has, the normal antibodies are IgG, IgA, and IgM, and your IgG are generally your main antibody. So if we were to look at those numbers normally, your IgG would be the highest level. Now in WM, the IgM is going to be quite high because your abnormal WM cells are producing the abnormal paraprotein. That's going to cause that to be high. But not only that, it can affect the production of your other immunoglobulins. So often patients can have low immunoglobulins. And in this study of 200 patients, over half of them, and there are other studies that say up to 80% of patients with WM might have low normal immunoglobulin. So that is going to mean that you're predisposed to infection if you're not producing enough of these normal antibodies. We know that it's not as simple as just that one problem with the immune system. So we know that WM, like I said, B lymphocytes closely interplay with T lymphocytes to help each other function. We know people that have a B cell disorder, such as WM, can affect their T cell function as well by mechanisms we don't really know how, but it does seem that people can have impaired T cell function as a result of the lymphoma itself. But also some of the treatments we give for the lymphoma can affect T cell function too. The other thing is that you can have a low neutrophil count, so that's neutropenia. So anything emia generally means low. So anemia is the low hemoglobin, hypogammaglobulinemia is the low immunoglobulins, neutropenia is the low neutrophil count. So that could be because if you've got a lot of WM in the bone marrow, it doesn't allow you to produce the neutrophils to the normal level. It could be because the treatment for the WM can cause the low neutrophils, and that's going to make people more prone to bacterial infections. And then, we know that you are people not necessarily just with WM, but also with other potential medical conditions that also need treatment that can also have an impact on the immune system. For example, one of the most common conditions, diabetes, we know increases the chance of some infections as well. And so they can all add up. And similarly, the immune system, like every organ in all our bodies, as we age, becomes less functional, if you like, or not as effective. So the immune system of someone in their 70s or 80s generally is not going to be the same as when they were in their 20s or 30s. So all these things can have an impact and make people more prone to infection. And so why is this important? So this is from a very recent paper looking at the SEER database of basically outcomes of anyone, a substantial proportion of people in the US who have been diagnosed with WM, and looking at the incidence of cause of death. So sorry to be quite blunt about it, but what they were looking at was in this big population study. So the SEER database collects data from, can't remember what percentage of the US population. It's not everybody. It is a significant proportion of the US data, cancer data gets fed into this database. And then this group can apply, or any group can apply to get that data and analyze it. So this group looked at basically all the patients with WM and looked at their cause of death, and what they were looking at to see and how they split it was, did they die from their WM, which was the index cancer death, this black line here? Did they die from another cancer, which is this second malignancy, which is this red line here? And then, or did they die from deaths that weren't cancer related, which is this dotted green line here. So this 0.0 is from when a patient was diagnosed with WM. And then as we have longer follow-up of the patient, so you can see these lines go up as people die from one of these three causes. And so that you can see that actually more patients in this follow-up that is going out to almost 10 years after diagnosis, that more patients died from non-cancer related causes than they did from second cancers or their WM. And heart disease was the most common non-cancer cause of death in this green hash line, but infection was the next most common thing. And when they compared the population of patients who had WM, who died from infection, compared to a population that is matched for the same age, sex, and ethnicity, infection, particularly in those under 50s, patients with WM were 19 times more likely to have a death due to infection than someone who didn't have WM. It became less pronounced in patients as they got older because there were more other reasons why patients were dying, not necessarily because of their WM, but because of heart disease and other things that are more frequent as we all get older, such as second malignancies. But particularly in those patients under 50, where, we know most people aren't going to die as young as that infection was a major cause of mortality. So it is an important factor that I think sometimes when we just focus on the treatment of WM, that we forget how important the infection side of things is. So I've probably all scared you all, and I don't mean to do that, but it's good to be aware of that. So then we can then move on to, okay, we've seen how bad it is. What can we do to protect ourselves? So I think of it in different stages. So first of all, I guess what we can do is try and minimize exposure to pathogens and to bacteria. So the less you're exposed to things that can cause infections, the less you're going to get an infection. I know it seems obvious, but it is worth saying that no matter, you may have no immune system, but if you never get exposed to an infection, which I know is not really realistic, it doesn't matter if you don't have an immune system. So one thing to think about is how much exposure you have to pathogens. And obviously that means then that a lot of our clinic appointments we discuss where patients ask, is it all right for me to go traveling? Is it all right for me to go to this wedding because I'm going to be seeing lots of people? And it's very hard. And eventually, ultimately, what I tend to say to patients is, look, there's no getting away from it. If you're in a big group, you are more likely to get an infection. I can't make that safe for you. There are things you can do to make it safer. So, good hand hygiene, trying to avoid people with runny noses. Some people wear masks as well to try and protect them too. But the more you're out and about, the more likely you are to get an infection. If people want to meet friends, I would say that meeting them outside in the open air is better than in a stuffy room with not good ventilation, etc., etc. But there is that, and I guess everyone has to take the risk that they find acceptable to them, because equally you want to carry on living your life. You don't want to sit in the house on your own doing nothing necessarily. And so you have to find what balance of risk you are comfortable with. Then the next thing we do is say, okay, we know that people are going to be exposed to pathogens and infections. How can we protect as much as possible? And so this is where vaccination comes in, which is a key part. We know that because the immune system isn't functioning as well as it should, that people with WM who have vaccines don't necessarily mount the same response as people who don't have WM. So there may be impaired vaccine responses, but that doesn't mean that you shouldn't have them and that they're not providing any protection. So we would definitely be recommending vaccinations. And on the next slide, I've got a bit more detail on the specific recommendations we give in the UK. Then I think the remaining 3 points that I've put there are really for people who are getting recurrent infections, because ultimately we haven't got very good tests for testing how one patient asked me this week, how immunocompromised am I, or am I immunocompromised, or how good is my immune system? And it's not really a binary thing of, oh yes, it's good, or no, it's not good, or even a percentage, because there's so many different bits to the immune system and they all help fight different infections and are better for certain infections than others, that we've got no good tests really for it, because even though I've told you we can easily check antibody levels, for example, those immunoglobulin levels in people, the number doesn't necessarily tell us everything, because it doesn't tell us how well they're functioning. And all doctors who treat patients with lymphoma will have lots of examples of patients with antibody levels that are in the normal range, but who get lots and lots of infections. But also the converse is true. We have some patients whose antibody levels are particularly low, and they go out, they're partying all the time with lots of people and never seem to pick up any infections. So ultimately, we don't have good tests to be able to say absolutely how effective your immune system is. And probably the best test is taking a good history from patients to see how many infections you are getting and how severe they are when you're getting them. And if we're worried, then the first thing we would do in the UK is consider giving antibiotics as a continuous thing. So not to treat infections, but to try and prevent them from happening, or basically to lessen their impact. So to give regular antibiotic prophylaxis. If that's not effective and we're still seeing patients get what we call breakthrough infections, that despite the prophylaxis, they're getting infections, then and their antibody levels are low, then we might think about immunoglobulin replacement as well, to try and boost those antibodies from other people that's collected from blood donors, to give them to patients to help protect them from infection. And of course, we will advise you, if you do get an infection and you're getting worse, don't sit on it, particularly if you're on treatment. We want to know about it sooner rather than later, so that we can go in early with the antibiotics. So UK-wise, our vaccination recommendations are as follows. So we suggest to all our patients that they have the annual flu vaccine and they have the COVID vaccine as advised by the government, which is usually at the moment, I think it's about 2 times a year. This is our advice. Not everyone chooses to take that advice, and obviously that's fine, because you're the boss of your own body, essentially. We can only give the advice. We also suggest to patients to have the pneumonia vaccine, and there have been studies that have shown that a particular there are different pneumonia vaccines, and the standard one we give in the UK for adults is this vaccine called Pneumovax 23. But there have been studies to show if you give Prevnar 13 first of all, followed 2 months later by the Pneumovax 23, that may, in patients who've got an altered immune system due to lymphoma, lead to better responses to the vaccine. So that is generally our recommendation if people haven't already had the pneumonia vaccine. And then recently, We've had Shingrix vaccine available, so that's the shingles vaccine, which when it first came out, this is the non-live shingles vaccine. We had a restriction on the ages that we were able to give it to, but recently this table is no longer in date because recently anyone who's immunocompromised is eligible for the shingles vaccine. So we would give it to any patient with WM. They've rolled out the RSV vaccine, but just for patients of a certain age, but that may increase with time and they may offer it to all patients soon. And then it's avoiding live vaccines in case of the risk of infection. So immunoglobulin replacement, this is from blood products. Oh, that's gone. That wasn't supposed to be there. That reference is for the next slide. Apologies, that's appeared there. So it is from blood donors, and for us in the UK, it's expensive, but more importantly, a precious commodity. We don't have so much of it. So they are quite strict in the UK as to who is entitled and eligible to it for it. But like I had said before, there's two separate things that we tend to think about is that you have to have lab proof of low antibody levels. So for us, it's either the total IgG is less than 4, or if it's higher, but you've got a documented lack of response to vaccine. So the antibody number doesn't matter, but if we're proving that those antibodies aren't functioning in the way that they should, then that's also a sign of essentially functional low immunoglobulin levels. So you might have the COVID vaccine or pneumococcal vaccine, and then 4 to 6 weeks later, we'll check to see whether you've developed antibodies to the vaccine to check that it's worked properly. And if it hasn't, then that would be lab proof there. Plus, the clinical side of getting the infections. Like I said, because we haven't got good tests, we need to see both the clinical recurrent infections as well as the lab side of things. I think outside the UK, some people would give immunoglobulin replacement just on the basis of a very low IgG, particularly if it's less than 2. But as I say, at least in the UK, we need both aspects. But one thing to think about is that these antibodies are antibodies that have been, as I've said, collected from other people that have donated their blood. So they generally protect against infections that other people and people with normal immune systems have been exposed to. So that's generally the upper respiratory tract infections. It doesn't tend to protect against recurrent urine infections or some of the pathogens that don't cause problems for people who've got a normal immune system. So they won't necessarily mount an antibody response. So it is worth thinking that this is generally going to help with people who get those recurrent throat problems, sinus problems, chest problems, rather than other infections. So this was a paper or the abstract from a paper that was published a few years ago, looking to see out of the interventions that we do for patients with blood cancer. So it wasn't specific to WM, but patients with CLL myeloma or non-Hodgkin's lymphoma. So all things that we know can suppress the immune system in similar ways to WM. Which one of these things, and this wasn't randomized, but it was just looking at patients who had immunoglobulin replacement or antibiotics or vaccinations to see, or looking at studies that had explored these and comparing all these different studies, which thing had the most impact on reducing infections. So, it's not randomized, but we can see that the studies that have been published that looked at the use of immunoglobulins, so that's the immunoglobulin replacement, that those patients who had it had about a 30% reduction in the number of infections they had, but actually no difference in survival between those that had immunoglobulin replacement versus those that didn't. Antibiotics didn't seem to make a difference to the number of infections people were getting. And vaccinations, once again, people had fewer documented infections if they've been vaccinated compared to those that didn't, but there wasn't an effect on survival as well. So we don't really know how much all these different interventions do add to things, but it's not a reason not to do it, but it's probably a reason that we should be studying this more. And talking of studying it more, I think the last couple of slides are just things just to think about that I think maybe we're starting to think about in our field is whether the treatment of the underlying disease, does that cause more problems to the immune system, or actually could it be helpful to the immune system? So if, for example, we're reducing the level of WM, are we actually improving your immune system in doing it? I think in years gone by, when our mainstay of treatment was chemotherapy and giving chemotherapy, we generally thought that actually that's bad for the immune system because it wipes out all cells. But now that we've got more and more targeted inhibitors, and particularly BTK inhibitors in WM, there is a suggestion that some of this may actually lead to an improvement in certain aspects of the immune system. Now, I mean, I put that as a caveat because this is the number of infections people got on the Aspen study. So this is the large study that was randomizing patients between zanubrutinib and ibrutinib for WM. And, the main thing was looking at how effective it was and the response rate. But some of the other things they looked at were the side effects associated with both of them. And you can see from when patients started either zanubrutinib or ibrutinib, that actually over half of the patients, within a year had developed an infection. So you're looking at, particularly in that first year, a lot of infections occurring. So that could be, partly the WM, but it could be the drug that's causing it. But there is also other papers, particularly in the field of CLL, where we also give BTK inhibitors like ibrutinib and zanubrutinib, that actually some of these BTK inhibitors may lead to a decreased risk of infection and some recovery of the immune system and antibody levels as well, so that they may indeed help the immune system. So I think that will be something that, going forwards, people will look at in more detail. And then the other thing that, again, I get asked about a lot, and to be honest, I don't have a lot of information, but there is increasing evidence that exercise can have an impact on the immune system. And there have been studies in a normal population, so people who don't have lymphoma, and when patients that have, or people that have exercised versus people that don't, you've got more of an active, younger, more functional immune system post-exercise than the people who don't. And they're starting to replicate those studies in patients with different cancers, including lymphoma and CLL. And there is a suggestion that exercise can help potentially with some of the immune cells and reinvigorate them, if you like. And this is it's an area of active research. We've got a colleague not so far from us that's doing a lot of work in this, but there's lots of centers around the world, and not just looking at if you exercise, is your immune system better, but also investigating what's the best type of exercise and whether it should be personalized. So would some people, their immune system be better if they did weight training rather than aerobic exercise, for example? So I think over the next few years, we'll understand more about exercise and similarly about nutrition. So you may have questions about that I can't answer, but it is an area of interest. So this is just to summarize what we've talked about. And I'm not going to read it out again to give us a bit more time to have a discussion, but I hope you found that useful. And I'm going to try to stop sharing. I'm back now. I can see you. So I'm going to look at the chat. So uh, I am going to go in order of the question. Does an antibiotic prophylaxis lead to resistance? So that is a good question, and it is weighing up the benefits versus the potential side effects. For us, if patients are getting recurrent respiratory infections, we do give antibiotic prophylaxis, and our general thing is to give azithromycin 3 times a week is our routine initial one, but we will tailor it according to if we see specific infections. We don't tend to find resistance using that. But so we don't have evidence of that with the antibiotic strategy that we use. So then there's another question on Prevnar 13 versus 20. So at the moment, I don't think we have access to 20 yet, but I think when that changes, then our advice will change to move to 20. But at the moment, we're still Prevnar 13. Could you touch on the importance of vitamin D for treatment success and immune function? So that's a tricky question. I think that, a lot of people are low in vitamin D, and there's been some studies looking at people's immune system and their outcomes to lymphoma in general. And those that have low vitamin D tend to have less good outcomes. But we never know with those kinds of studies whether it's what we would call a confounding factor. That is it because of the low vitamin D, or is it that the low vitamin D is more associated with other problems that could be the cause? So essentially, I would say that we tend to replace vitamin D because it's quite simple to do and it's not going to harm people. So we would always recommend to doing that. But I don't know really how much evidence there is about it helping a lot with reduction in infections, but we would do it. So and we would recommend it. So the questions are coming in thick and fast now. So what part of the immune system might help decrease fatigue, almost independent of the IgM level? I think that's the million-dollar question because, there's sometimes with tiredness and fatigue that there's things that I can easily say, this explains it. So if someone's very anemic, then I can say, oh, it's probably because of the anemia, at least in part, that's causing the fatigue. But, we have lots of patients that aren't particularly anemic, who've got WM, who are very fatigued and very disabled by the fatigue. And we don't really know, and there isn't anything we can test to know why they're fatigued and therefore what to do about it. So it is a tricky one. And and it's a hard one to also assess because your interpretation of fatigue may be different to mine, may be different to the next person. So generally, if someone comes and they are very fatigued, I would be looking to see what's the degree of burden of disease, and is this a reason that we should be treating their WM, potentially accepting that a lot of the time, if there doesn't seem to be much disease there, then by treating it, we don't necessarily improve the fatigue. Sorry, that's a wishy-washy answer because we don't really know the answer. Chinese doctor used to give me pills and herbs to boost the immune system. Is this nonsense? I would say that we practice evidence-based medicine, and by that I mean I need to see a high-quality study showing ideally half the people having these pills and half not, and showing an improvement, and that's the way to show that something's effective. Now, just because we don't have those studies doesn't mean that those pills and herbs don't work, but I don't have the proof to prove that they work. So they're not something that I would recommend. But equally, I wouldn't just dismiss it and saying it's nonsense because there's no evidence there, because the studies haven't been done. So I think the best thing to do is, what I tell patients who want to take lots of supplements or alternative therapies, as long as it's not potentially interacting with their current treatments, because I do tend to tell patients not to take it if they're on therapy now, that at worst, perhaps it'll be a financial issue because these things can get expensive. But if you're finding that they're helpful, then take them. What is risk of WM mutation to other blood diseases? Is it affected by other treatments? Um, so, what is risk? So, I think that means what's the chance of other secondary cancers? I think that's what I've understood by the question. So, I think there are certain WM can rarely transform into a high grade B non-Hodgkin's lymphoma. So, that is probably because the cells themselves mutate and become more high grade. We don't think there's a treatment that makes that more likely. It's just a rare complication of the disease itself. But there are certain other things that we know, particularly with the chemotherapy, that can increase your risk slightly of what we would consider unrelated second cancers. So, some of the chemo trials that have been performed, you will see that there are a small proportion of people that develop a problem called myelodysplasia, and some of those people with myelodysplasia can form into an acute leukemia, and that's where that myeloid cell line, where those cells don't get produced properly, and then some of those can become leukemic. So I don't think it's caused by the WM itself, but more likely by the treatments. They're still very rare and it's still unusual. So obviously, we still give chemotherapy as our first line treatment off trial for WM, and we would still definitely recommend that because most people aren't going to get MDS or an acute leukemia. But it is a higher proportion of people who do than the general population, and it's probably as a result of the treatments that we give. We're not aware that BTK inhibitors increase that risk, but they will always report second malignancies because we know having an altered immune system in itself is going to predispose you as well. So I ended 6 cycles of BR in November. Need a hip replacement. Is there a period when the immune system would prohibit surgery? And so someone has replied saying that they've had hip replacements 3 and 6 years post chemo. So I think there's different bits to the immune system, and the main thing that protects against bacterial infections, which is what we're worried about when it comes to operations such as hip replacements, are your neutrophil count, and they recover pretty quickly after after chemotherapy. So, most of you, if you're monitoring your blood tests, will see that your neutrophils will come up within a month or two after. Sometimes it takes a bit longer. We know that the rituximab in particular can suppress the immune system for up to a year or possibly longer after having rituximab. So when there were lots of studies in the when COVID vaccinations first came, that if a lot of people who had an impaired response to the COVID vaccine, one of the risk factors was rituximab within the year of the vaccine. So we know that there is still some impairment to the immune system, probably up to a year after. Also, obviously, the WM can affect it as well. So I would say, in answer to the question, that obviously you need to discuss it with your hematologist and the surgeon in terms of finding that right balance of how urgent the hip replacement is versus how long is okay for you to wait based on your bloods and the recovery of your neutrophils and your lymphocytes and your immunoglobulins. Things can be done to kind of make the surgery safer. So whether you need immunoglobulin replacement or antibiotic cover, for example. But if it was urgent, I would say that we have had some patients within 3 to 4 months have major surgery after chemo. So it kind of depends on really how urgent it is. Does infection that needs reporting to your doctor include fever, or does a non-fever infection need treating as well? I think both need treating. It's just a question of how urgently you talk to the doctor, because a lot of infections will go with time. I think if you're on treatment and there's a risk of neutropenia, you need to tell people straight away, or medical teams straight away. If you're not on treatment and you're getting a cough, a cold, particularly if you're not necessarily getting fever with it, then I would be telling the doctors. But if they're persistent and they're not resolving within a few days, and if you're getting recurrent problems, particularly, then yes, because we sometimes get our immunologists involved. We sometimes get our head and neck team involved because they might want to look to see if there's anything else predisposing you to sinus infections. They might want you to have kind of the douches or the nasal sprays to wash out to help really clear the sinuses. And if you're getting recurrent sinus infections, that may be a sign of the low antibody levels and needing antibody replacement potentially. So if someone's in remission, meaning blood test back to normal, would they still be immunocompromised? So I get asked that question a lot. And ultimately, like I said, we haven't got a good test to tell that. I would say that you've recovered from the risk of the overwhelming sepsis and the severe infections, but you will still potentially notice that you're more prone to viral infections. But the best test is how many infections you're getting, essentially. So again, it's so variable because we all come with different levels of quality of immune system, if you like, that it's and we don't have good tests for it. What about LPL with IgG? I think when it comes to infections, it's the same. So everything that I said still holds true, that you can still get the low antibody levels. What I would say is it's just harder to interpret the IgG level if you've got a paraprotein that's kind of raising your IgG level, if that makes sense. So, when I said our criteria for eligibility for immunoglobulins, that we wouldn't be able to assess your immunoglobulin level as less than 4 because your paraprotein is going to make it higher. Can boosting your immune system or immune response from an infection cause your body to build more monoclonal IgM and speed the progression of WM? We don't have evidence of that, so we don't think so. But yeah, so I've never seen that. We sometimes see that patients can get a reactive thing to some infections, but it tends to, so all vaccinations. So sometimes if patients have enlarged lymph nodes, then once they've had the COVID vaccine, we've noticed that they can sometimes get a bit bigger again, but then they tend to go back down again. So I don't think it speeds the progression of WM. We don't have evidence of that. Why is chemo or BR the first line here, but in the US, you'd be able to start on a BTK inhibitor or on BR? You've discussed with Dr. Castillo at the Dana-Farber, and it's just a question of first line treatment. Now, it's tricky. It's the same in the UK. We still have access to chemo plus rituximab, and it works in terms of the effectiveness very well. So for us in a National Health Service, where BTK inhibitors are expensive and you're trying to think about what's best for the population, the economics doesn't stack up as a health service, essentially. And this is how NICE made their decision to have BTK inhibitors frontline. But it makes sense to have it in patients whose disease has come back. So it's a health economics thing. There's no head-to-head study to definitely know one is better than the other. And important, obviously, whenever we're looking at drugs, is not just how effective the drugs are, but it's also the toxicity aspect. And I think, there are toxicities with BTK inhibitors. Yes, it's not a chemotherapy. Yes, it may not have such an impact on your immune system, but it has its own potential side effects as well. So I can understand your dilemma if you have got the potential for both. But I'm quite comfortable giving chemo and rituximab because we've given it for many years, and it works well for many patients, majority of patients with WM, and we can tailor it according to the patients. Um,
Uh,
yeah, that's probably all I'm going to say on that for now. So
I just
someone's
I just wanted to interrupt for a minute. We're a little bit after 5 o'clock, so if you wanted to answer one question or two questions and
There's a
whatever.
couple more questions.
Yeah.
I'm happy to keep going.
Okay. You let me
Um,
know when you're done.
I have LGL leukemia as well as WM. So when neutrophils fall, is bone marrow biopsy the way to help determine which blood cancer is active? LGL leukemia is a problem with the T lymphocyte. So it's a T cell clone. And although they sound completely unrelated, we do know that there is a slight association. So it's not totally unusual to have a B cell clonal problem and a T cell clonal problem. And you're right, when the neutrophils fall, it can be difficult to know which one is the more active. I have to say, if it was specifically the neutrophils falling and you're not on treatment for WM, that sounds more typical of LGL because WM seems to affect the hemoglobin more than the neutrophil. So if I had to guess, I would say it's probably more the LGL. But you're right that the only way really to know is to look at the factory where you produce the blood cells to see. So I would probably agree with you that a bone marrow would help determine which one to treat because of that. Then the last question I can see here at the moment is how common is it for WM people to get pneumonia? Is there a frequency? I'm not aware of good frequency data with pneumonia specifically, but we do know it is common. Probably in our cohort of patients, though, we're probably looking at in terms of significant infections. I would say around 10 to 15%. But generally, what we find is that it's patients who start to get infections often are the ones that get recurrent ones. So rather than everyone getting it once badly, if that makes sense, that we get some patients that don't get any problems or very rarely get problems, and then some where actually the infections are far more problematic for them than the WM itself, if that makes sense. And I know it's kind of related to the WM, but not the lymphoma aspect of it. So, yeah, that gives you a ballpark. And I think I've got to the bottom of the questions.
Well, thank you so much. Thank you, thank you, thank you. You have brought some clarity to the whole issue of what is my immune system and why is it all fussed up and what's going wrong and what can I do about it? So you took a very complex topic and you made it understandable and very relevant and reassuring as well. And we're extremely grateful for your time, your
Oh, no
energy
problem.
that it took to prepare this presentation, and all the questions you answered. Like you just went through them all, and we really appreciate that too. So thank you for sharing your expertise with us today, and we look forward to hearing from you again in the future.
Well, I hope next time in person. I would love to come and visit you all.
Well, you know what? You've offered, and we will take you up on it at some point.
Excellent.